Hello, everyone. Good morning, good afternoon, good evening, as the case may be, wherever you are. It's 6 a.m. for the speaker in Madison and almost 11 p.m. in Australia. So we are in a large time zone. Thank you all for your participation in this today's webinar. I see that we already have 500 participants and they are growing at a very fast pace. So welcome all of you to this webinar of today. I will introduce the speaker, and the speaker today is Professor Robert Jeraj. He is Professor of Medical Physics, Human Oncology, Radiology and Biomedical Engineering at the University of Wisconsin-Madison. He is also the Professor of Physics at the University of Ljubljana, Slovenia, where he looks after and leads the research group in medical physics. He is also involved with and is founder of the Topical Group on Medical Physics with APS and Working Group on Future of Medical Physics Research and Academic Training with AAPM and Medical Physics Without Borders. He is founding editor-in-chief of the Biomedical Physics and Engineering Express Journal. He has served as a member of the Medical Physics Drug Advisory Committee at FDA and is on the board of CAMPEP. He has authored more than 150 papers, textbooks, or book chapters, and his interest has been in molecular imaging, in therapeutic intervention, and general application of medical physics in radiation and biology. Today we are honored that he is going to talk to us on reigniting the role of medical physics in medicine, and he will be touching upon new opportunities for involvement of physics in medicine beyond the traditional role, and also trends in personalized medicine, strategic initiatives, and highlight the need for additional skills and knowledge required to tackle the changes. He will give examples of physics involvement in medicine beyond traditional role of medical physics. You can add your question using the Q&A in your screen, and you can use the chat for social functions. And with that, I will pass on to Robert. Robert, the floor is yours.
Thank you, Madan. Thank you very much for invitation to this webinar. And particularly thank you for all many participants. I guess we're nearing 700 now, all around the world. It's really so nice to see when the messages are coming from just every part of the world showing where medical physics is. So, as Madan has said, today I'll be talking about reigniting the role of physics in medicine. And for some of this might be a little bit of surprise, seeing how medical physics is really flourishing around the world. But I'll give you some reasons why we do need to maybe take some action together. So first, just like brief disclosure, I'm a founder and CSO of AIQ Solutions, a startup starting from University of Wisconsin. So let's start with where is medical physics now. And I'll show you that there are some worrying data that we should not dismiss. A little over 10 years ago, my dear colleague Thomas Bortfeldt and myself, we were contemplating a little bit where medical physics is and where it's going. And one of the things that we postulated was that actually the medical physics is really a chain that leads or starts from cutting edge research through translational research to technology improvement and finally clinical implementation. Each of these important parts has its own timeline. with cutting edge obviously being at the forefront, taking approximately, say, 20 years before the innovative idea then hits the clinical implementation. And of course, clinical implementation that's what people in medical physics do every day in the clinic. What we also observed and postulated was that actually what we are seeing right now is that there is a lengthening or stretching of the cutting edge research, rather, in other words, weakening of the important link in the chain. And that itself, of course, increases the time from translation to then clinical implementation, which of course means that itself is weakening the field of medical physics. Now, one could say, okay, well, this is what you think, but maybe that's just your perception. So let's see if that's true or not, at least some indicators that we have. So again, Thomas Bortfeldt, a few years back, tried to map the landscape of medical physics. And what you see here is a coordinate system of medical physics with the application, the main application on z-axis, or z-axis, say upwards between imaging and therapy, two main parts of medical physics. Then the four areas that I mentioned before on the y-axis or the left axis, and then the scale of tools that medical physics uses on the x-axis. And then what he did, he took the very best of AAPM research that's usually presented within the Young Investigator Symposium and mapped it onto this coordinate system. And what realized was that actually there was nothing that could be classified as cutting edge or foundational medical physics. So it seems as our horizon would be ending here. Again, somebody could say, well, this is one experiment, and maybe that's not quite completely fair comparison. But then there's another piece of data that was compiled by Brandon Willen from University of Sydney, where he was mapping the total amount of grants that AAPM members, American Association of Physicists, Madison, and obviously not a representative sample of everywhere what's happening in the world, but it's still an important component in medical physics space, seeing that while there was significant increase from 1985 to about 2005 in grants secured by AAPM members, that plateaued and actually started to decrease in 2000s. Here I'm showing an example of a word cloud of typical grants and topics that were held by, or they're held by AAPM members. And we can see in the center, no surprises. Imaging, cancer, MRI, PET, breast, radiotherapy, quantitative. And with a little bit of other things coming in. So clearly very much the cross-section of what we see today. Now, there is actually even more dramatic relative decrease. In the last 20 years, the AAPM membership increased from about 4,500 to about 9,000, so essentially doubled. While at the same time, the number of members that hold the grants had decreased from 3.4% to about 2%. So this is indication that about essentially we are dealing with around the same number of grants, slightly less, as I showed you earlier. However, with the continually increasing membership, that means that the clinical parts of medical physics are increasing, doubling essentially in the last 20 years, while the research components are remaining largely flat. Now, that itself, one could say, well, it's hard to get the grants these days. It's hard for everyone. But if we look at comparison between the biomedical engineering, a very near and very important collaborators, we see that in the last 20 years, they essentially tripled the number of, in this case, NIH grants funded and given and awarded to biomedical engineering, while medical physics, represented by radiation, diagnostic, oncology as the main components, largely remained flat. So that means that some of our sister societies are doing way better, are much more important, getting important footprint in the research space, while the medical physics seems to be stalling and losing its way. By the way, this is a highly recommended review and also future-looking paper from Brian Pope, recently published in Medical Physics, where you see this and some other statistics. So what can we expect in the future? Clearly, the winds are not blowing in the right direction. So the pressure, obviously, with this trend is going to further shrink our horizon. So what I showed and postulated at the beginning, essentially, we see that that's really happening. So what do we need to do? And this is actually also led to the title of my lecture, is reinvigorating, reigniting the strength of medical physics. And in particularly what I think here is reinvigorating the physics component, the research components of medical physics. So it's able to sustain the ever increasing number of medical physicists that we see. So as I mentioned, what we need to do is to reignite. So this is medical physicists talking to medical physicists, but are we the only ones that were observing these trends? Let me go back. There is an interesting initiative by National Cancer Institute, directly coming from the director's office. Anna Barker, she was the deputy director of the National Cancer Institute. Over 10 years ago, NCI realized that physics has a lot to offer to oncology. But what was interesting was when they were designing this initiative, one of the persons that they called was Paul Davies, that many of you might have heard, or most likely, if you especially are coming from physics, reading some of his books. Cosmologist, astrophysicist. And then I'll just read some from this Nature piece that described the formation of this physical science and oncology. So Anna called Paul and it says, does he want to participate in this initiative? And then he said, Paul said, sure. And at that time, he barely knew what NCI even meant. He said, but I don't know anything about cancer. And then Anna replied, that's okay, we are after fresh insights. And with that, says David, he was hooked. If it had been just, give us another beam, I wouldn't have been interested, he says, referring to X-rays, particle beams, magnetic resonance imaging, and the many other tools that physicists had provided to medicine. But an opportunity to contribute entirely new concepts and ways of thinking, now that, says Davis, was exciting. If this was not direct slap at medical physics that we know today, I don't think what it would be. Not to say that it's not important what medical physics has achieved, far from there. It basically just means that it needs to rethink how physics can contribute to medicine. So essentially, this initiative led to the Physical Science and Ecology Centers, later formed in a network. This was a large network that got investments of over $100 million. But interestingly, very little, or actually almost none that I know, went to traditional medical physics. And you can see why. There was another interesting commentary done by my good colleague, Bob Austin, that I like to read. So, and he said, Paul is wrong sometimes, but he's not afraid to ask a very naive question that gets at the heart of the matter. In other words, it's nothing wrong to be bold, sometimes wrong, but ask questions. He also mentioned, I worry that we'll become conventional, another failed assault on cancer. I really hate the thought that in 10 years, we'll find we haven't accomplished anything. And in some way, that has been true. Over 10 years, over $100 million, one could say that some of this initial spirit has been lost. It's now mostly linked to systems biology, biological, in the division of biology at the NCI. However, important to medical physics, because of our connection to them, it led to some important medical physics initiatives that I want to just briefly summarize. So as I mentioned before, the landscape that was crafted based on the AAPM presentations, we are putting quite some thought of what to do, how to reinvigorate that in AAPM. And one of those initiatives is also the Working Group Future that I'll mention a little bit earlier. But one of the important things that we realized was that, at least in the US, what we faced was losing connection to the motherhood of physics. And that is the main society. This is American Physical Society. So Bob Austin, the one that I mentioned earlier, and myself, then we initiated about 5 years ago a new topical group for medical physics within the APS. And this was the first time that medical physics was sitting with the 30 other subfields of physics at the same table within one society. One thing that we did want to make sure is that we don't lose the bridge between the two societies. So we're putting an extra effort to make sure that both the activities within the APS and within the AAPM are connected, that we have the flow of the ideas, of initiatives, and a lot of things that we're doing in common. So while, of course, we had to recreate this connection in the US, many countries I know for the fact around the world have it already. And this would be my pledge: don't even think about damaging any connections to the physics. That's a very important one. That's where we get a feed of our new students, new blood. And this, I think, is really one of the very damaging aspects that we lost in many countries, where we lost the connection to undergraduate students and all the activities, as opposed to, for example, biomedical engineering, that has established itself also as the lower levels of education, not just at the graduate level. So another important initiative, one of the many of the so-called expanding horizons initiatives within the AAPM Working Group Future, was the so-called provocative questions for medical physics and oncology. We initiated this in 2016. We modeled after NCI's provocative questions, and started from the membership, but then reduced to about 18 provocative questions and identified 10 barriers at a targeted provocative questions workshop that included both medical physics, other sciences, and medical sciences as well. And I just want to bring up the word cloud from the provocative questions, thanks to Madan Ebert from University of Western Australia. And I would like to point out to some of the topics that emerged as the most important ones: resistance, physical systems, state, critical system, plasticity, immune states, dynamic, transition. So if you compare this to the current world cloud of medical physics grants held by AAPM members, you see quite significant disconnect. And this is an important thing to keep in mind. Not saying that everybody should be working with this, but obviously there is some merit into looking into this space. So this initiatives have been further expanded by ESTRA Future, European Radiation Oncology Society Physics Future Initiative, with the so-called grand challenges for medical physics and radiation oncology. So this was specific to radiation oncology. It was initiated in 2019, modeled after AAPM, and started from there, again, involving membership, and but taking a little bit different approach by boiling down to 4 grand challenges and discussed at the targeted workshop that I'll mention just in a second. But there were some very important general problems identified. The first one was that medical physicists do not follow medical trends in sufficient detail, aside of radiotherapy and imaging developments. So most of medicine beyond that is pretty much not covered by medical physics. What a missed opportunity. So medical physicists are also not sufficiently involved in direct data gathering. They rarely design and lead clinical trials, and rarely design and lead biological experiments. Very important components. That's essentially, I like to say, the lab for medical physics is in the clinics or in the lab. it's not just like phantoms, it's not just the machines, it's actually the data that we need to try new tools that we develop in clinical trials and verify, or basic experiments. And very importantly, medical physicists are not even properly trained for the future. They're missing a lot of mathematical physics training that's important for modeling. Biology training is limited often to radiobiology, but even that in a limited sense. Very important trends that are coming through big data. Training in that is limited, and then also limited training in statistics, important components of conducting clinical trials and biological experiments. While of course we discuss all this in the context of oncology, the same applies to other fields. So the 4 grand challenges that were summarized, and you can see the word clouds important in that, but you can also read that in the recently published paper in Radiotherapy and Oncology. Are the target definition, felt important to transform it from art to science. So a lot of important components for medical physics to contribute to better understanding where the tumors are in radiation oncology. Obviously, artificial intelligence, development and implementation of AI. Where is the medical physics there? How to bring that, how to implement that into the clinic. Modeling biological effects in the era of personalized radiation oncology. And the finally important part is how to design the leadership of medical physics in the changing world of radiation oncology. And of course, again, as I mentioned, all that can be read in the listed paper with much more sufficient detail. Watch this space. There will be more target initiatives coming. I know that all the ESTRA members, physics members, will receive an invitation to participate in focus groups around these challenges in the coming days. So if you're interested, get on board and participate in this initiatives. So now let's move to a little bit more of my personal part, aside of my involvement in these initiatives, on some of the research. There's no good talk that goes with some research, so I want to bring some of that as well here. But before going into that, I would like to bring out one of my favorite quotes from Rehani, who was director of National Institute of Health some years back, when he was justifying the budget for the NIH, National Institute of Health, towards the Congress. And he was talking about the future of medicine and summarized it as a 4 Ps of medicine. Essentially, medicine where we'll be able to predict how, when, and whom disease will develop. The medicine where we'll be able to precisely target treatment on a personalized basis. A medicine where this individualized approach will allow us to preempt disease before it even occurs, but only with participation of individuals, communities, and healthcare providers in a proactive fashion as early as possible. And we can see how this participation is incredibly important in the times of pandemic, for example. But anyway, I would like to focus more on the first 2 here, prediction and personalized, for this talk. As most of you are aware of some of the initiatives that were spurred from that, like precision medicine initiatives, the cancer moonshot, both in like US, Europe, as well as many other countries, targeted initiatives focusing on precision medicine. I believe most of you are well familiar with precision medicine, but just to summarize, basically the fact is that not all the patients are responding the same to any given therapy. And that's why when we have ability to choose different treatments, particularly in era where we have a lot of targeted treatments, for example, for cancer, we need to optimize the treatment and give the right treatment to the right patient. But something which is less appreciated, but a big headache for personalized medicine, is that just not as all the patients responded the same way to any given therapy, not all disease or disease sites within a given patient respond the same. So what we get is a tremendous heterogeneity of response, with some of the disease responding and some of the disease not responding in the very same patient. And I'll show you some examples of that. So heterogeneity of response poses a significant challenge to precision medicine approaches. Another important component and very recent trend that, again, most of you are very well aware of, and I would say it's a golden opportunity for medical physics, is the immunotherapy. It was declared a breakthrough of the year for 2013, and Jim Allison and Soku Honju received the Nobel Prize in 2018 for discovery of inhibition of negative immune regulation. And we'll talk a little bit more about that. The basis of immunotherapy is really in the hands of immune checkpoint inhibitors, or so-called ICIs. So immune checkpoint inhibitors prevent cancer cells from suppressing immune response. As we know, the cancer is so smart that it essentially makes it invisible to the immune system. So this immune checkpoint inhibitors are essentially taking breaks off the immune system. And by now, it's been reported incredible survival advantage in multiple cancers. And just for an example, in metastatic melanoma, before immunotherapy, typical median overall survival in metastatic melanoma was around half a year. With the first line of ICIs, for example, CTLA-4 inhibitors, ipilimumab, that increased to about 20 months. With the PD-1 inhibitors like nivolumab, it increased for like 37 months. And with the combination to incredibly 72 months. So that's the median overall survival. You see the survival curves here. So that's more than tenfold increase in the median overall survival for these patients with just one single type of therapy. So of course we couldn't go without getting our feet wet with this, with the research in this area. So I'm just reporting a little piece of it, but mostly focusing on the heterogeneity that I mentioned before. So what you see here in these graphs is a relative contribution for about 15 patients that were classified as either responders or stable disease or progressive disease. And clinically, these are clinical evaluations. But what you notice is that there is a quite significant number of patients that has at the same time both new disease, progressive disease, as well as responding disease, so green and red. And both of those are either in the responding category or progressive disease, clinical progressive disease response. What was interesting that we did use quantitative imaging aspects and advanced analytics to analyze each individual lesion separately. This is where it led to these graphs. But importantly, we discovered through this exercise a new biomarker, and that is the number of progressive disease. Not surprising that basically, essentially, the new disease and progressive disease is driving clinical response. Yet, that's something that had not been shown before. Importantly, this new quantitative imaging biomarkers predict clinical outcome months and years in advance. Very important information that we get. Now, if we stay with the immunotherapy, we cannot go around associated immune-related adverse events, which are extremely common as well. So as I mentioned earlier, incredible success of these therapies. However, for the combination of ipi-nivo, for example, it has just recently been reported that the level of adverse events approached about 60%. And these are high-grade 3 or 4 adverse events. So immunotherapy success comes at an incredible price. These adverse events are clinically impactful. Low-grade causes to pause of therapy, steroids. High-grade to hospital admission, permanent discontinuation, and also potential death. And if we were able to identify adverse events early, that of course has tremendous impact on patient care. Again, we took our favorite molecular imaging. We were not taking anything fancy, just simple FDG PET. It's commonly done in these patients, typically every 3 months. In the prospective or retrospective study and currently prospective study between 2 centers, we were aiming to identify early quantitative imaging biomarkers of adverse events. We were using, again, like some state-of-the-art analytics, using both convolutional networks for segmenting, but also developing, again, novel biomarkers based on the histogram of the uptake in the whole organ, something what we call the percentage of the uptake, which then lead into patient classification. And I just want to give you a brief example of a patient that was scanned. This is a standard clinical sequence of a patient that would be scanned with a melanoma. And what you see here on the bottom part of the figure are the histograms of the uptake in colon and in lung, and you'll see why. Because when you see that at the day 84, we started to see signs of inflamed bowel, which then increased at the day 173, further in day 273, where there was further increased an indication of increase of uptake in the lungs, indicating pneumonitis. And when we looked at the patient report that you see on the top, indeed, this patient was clinically identified both colitis and pneumonitis. However, when you looked at the graphs with the red and blue arrow, you see that imaging was able to predict weeks, essentially months ahead of the clinical presentation of this, that something is happening. What you see in the yellow band there is actually very nicely assessed uncertainty and normal range of this patient uptake that we would get across population. So essentially, as soon as these patients are crossing that point, that means that there is suspect for future emergence of adverse events. So very important finding. But then we were also confirming this in other adverse events. And you can see that very important clinical prediction of the future development of adverse events, as I mentioned, through this new quantitative imaging biomarker, which we called it the optimal cutoff on the histogram of the uptake on the FDG pattern. Now, let's move to a little bit different gear in immunotherapy. So for physicists, and I know there are many physicists in the audience, immune system essentially, and the regulation of immune system is essentially cancers create a negative feedback loop. So immune checkpoints such as PD-1 or PD-L1 are creating a perfect negative feedback, which essentially makes this, as I mentioned, cancer invisible to the immune system. So the immunotherapies essentially go into the blockade of this negative feedback loop with immune checkpoint inhibitors, the ones that I described earlier, essentially taking the brakes off, which essentially leads to strong amplification of the immune response. So basically just playing with these regulatory pathways within the cells, we're able to negate this, this negative feedback loop. So obviously, once we get a model, and that's what medical physicists do, then we try to describe this as how we would try to do. So this is some of our efforts that led into using mechanistic model. I don't want to go into detail because there's way too much complexity, but we took a simple model that essentially did model immunotherapy initially, was not validated, but importantly lacked a specific biology. And we added 4 important biological parameters: PD-1, PD-L1, so the expression, the important MHC class 1 expression, ability of tumor cells to present antigens, the mutational burden, and then the anti-PD immunotherapy efficacy. And then one of the things I want to point out, there is a big challenge to create models that are neither too complex nor too simple nor too complex. Because very often in the literature, especially not done by people that understand both sides, they would either create too simple models or too complex. So it's really almost an art to be just right. This is just an example of some of the sensitivity studies. Not going into details, just want to show that there's only one parameter that in our sensitivity studies showed to be able to predict responders versus non-responders. So something that I showed earlier or talked earlier, very important, to be able to predict whether immunotherapy was successful or not. And that was the MHC class 1 expression. So when we had a model, we said, fine, this is a model, but we got a couple of parameters and 3 parameters that so like we don't know whether it's true or not. So what we did, we designed experiments in 2 murine cell lines, one that was responsive to immunotherapy, one a non-responsive. We designed 3 types of experiments in anthemic nude mice to develop the growth parameters, the wild-type mice that we measured immunerelated parameters, and wild mice receiving immunotherapy that we were able to validate models predictive therapy. And then we used flow cytometry to measure all the parameters of the model, and finally did the sensitivity studies. So what I want to point out is what we designed was essentially design experiments exactly to test every single parameter that we had in the model itself, something that's very rarely done. Essentially, the physics was driving the experiments entirely. And again, not going into details, just showing the final part of the comparison. When you see the different cell lines in different mice, surprisingly, even as much we were careful, you see the natural variability of the growth for different mice, but also quite different behavior between the 2 types of cell lines or implanted cell lines. But importantly, what we found out was that good response to immunotherapy, it can only be possible when one would have homogeneous and MHC class 1 positive tumors, as opposed to poor response where you had a heterogeneous and MHC class 1 negative tumors. And again, this does not come with surprise. You see from a cartoon here from Current Opinion in Immunology, which shows that indeed, when somebody has a MHC class positive cells in a tumor, that leads to tumor rejection phenotype. When you start having an MHC class 1 negative tumors, that leads to either tumor escape phenotype that leaves the tumor there, or the dominant tumor phenotype that leads to metastases and then spread of the tumors. So essentially, our model predicted exactly what one can see and in observing in the clinics as well. So really nice match between the clinical and then fundamental basic science that we get. Okay. So this kind of like ends the kind of scientific part of presentation, but I don't want to stop just here quite yet. I would like to discuss where we should go from here. So to me, essence of physics is summarized in some way in the Rutherford experiment. And of course, there is much more to physics than that. But what did Rutherford do? Rutherford, I guess we all know the stories from our training in physics, basically did experiments on thin gold foils, trying to figure out how are the atoms made of, you know? And before that, there was a Thomson model that says like that's the mass in the atoms is uniformly distributed. But when Rutherford did the model, basically shooting alpha particles on this thin gold foils, figure out that most of the time the particles would just fly through, but occasionally would get like high reflection. So essentially that led to the current view of the atoms, that we know that we have like most of the mass concentrated in the nucleus and just a large electron cloud around it. So change the view of the atoms. Now, medical physics, I don't see much different from that. What we deal with is typically a disease within a patient, like a tumor. We have tools that we can monitor what's happening with the disease that we put around the patients, like imaging or other tools. We have the therapy that affects the system, like tumors, and we can see the transformation that happens after therapy. We can monitor response. So essentially, we have the same thing. So we have an unknown object that we intervene with, we look at the response, and then we monitor what's happening. And that can help us improve our modeling. But our modeling has to be built both on physics and medicine, which is an important enhancement and complication from just the physics part. But if you look at the physics, what did physics do to move from Rutherford's initial model of the atom? Got together in enormous collaborations that led to the discovery of all particles and standard model. So my hypothesis here is that medical physics has to do the same. We have to learn from our colleagues, physics colleagues, and establish global medical physics collaborations. So one of the steps to that actually goes to the recently established the International Council within the AAPM, led by Dr. Jatinder Palta. For those, again, this is one of the initiatives within one organization, and there are many others, but I just want to bring it up for those that not be familiar. So the AAPM-IC has 6 categorical committees, and one of those is also Global Research and Scientific Innovation Committee, the one that I shared together with Dr. Thank. And the main aim of this committee is to coordinate scientific collaboration, develop global research, provide mentoring opportunities, enable exchanges between AAPM and in collaboration with other international entities, group, and individuals. We don't pretend that we are the only ones doing that, but we would really love to partner with everyone who's interested in and get on board to basically create the very fertile international milieu. So there are some of the initiatives that we're launching as early in the first year. One is the Global Mentorship Program, where we want to increase the research mentorship by both providing exchanges as well as mentoring to very promising early career investigators. So if you're interested, let me know. The webinars, not to compete with IOMP webinars, but basically to supplement in a way on the research-related topics, highlighting our early career researchers. And then the international clinical trials. As I mentioned, that's one of the things where medical physics is lacking for that. So if you're interested in partnering, please let me know and let's collaborate. This is my pledge to basically come together. As I said, I firmly believe that we can only move together when we are together. And this also brings me to the summary of my talk today. So I hope I managed to convince you that medical physics is facing a challenging future, and we do need to act. We are clearly facing lack of innovation, foundational and cutting-edge research that needs to sustain and partner with other colleagues in medical physics that are working very hard for clinical implementation. And we're also losing research team compared to our sister disciplines like BME. There are several important initiatives, so please watch this space and most importantly, actively participate. If you're interested in any of the initiatives, let me know, or the colleagues, and just get on board and participate. Don't think that any place where you are is too small, that doesn't have resources. We need everyone to pull together. We definitely need to follow trends in physics and medicine well beyond what we currently do. It's very critical that we can add back to physics roots like APS, GMAT, and it's important to get in initiatives like precision medicine because it's really fertile common ground to expand our horizons. Very importantly, there is a need for global action. We need to follow lead from large physics collaborations, and importantly, everyone can contribute in every part of the world, and everyone should participate. So I hope at the moment 889 participants on this call, everybody gets together and help driving medical physics into the future. So let's reignite together. With that, I would just like to thank my research groups, both in University of Wisconsin and University of Ljubljana. As you can notice, this was taken pre-pandemic. Unfortunately, now our research has led into most of this type of meetings that we just currently have. But of course, that also brought the world together. It's much easier to get together now than it was in the past. With that, I would just like to thank you for your attention. Thanks again for IOMP for hosting this and opening it for questions. Thanks again.
Thank you, Robert, so much for the excellent presentation. Very invigorating, very thoughtful. You have convincingly put forward that how when the AAPM membership got doubled, the grant holders were not proportionately going up, rather staying. Sister societies had better performance. So the research component in medical physics has not been up to the mark. That point you have made very well. You talked about new beings, where they are, or what is the possibility, the physical sciences in oncology, and some people who are not afraid to ask provocative questions and grand challenges emerging from some of those, and reigniting, and then where to go from here. That's really a great feast for the participants today. We have a good number of questions. So my concern is that we have only 15 minutes left. So what we will do is whatever questions can be answered by Robert today, we will do that. and we will send the remaining questions to him, and he will try to attempt by email. With that, I see the questions in the Q&A box, and the chat box is so difficult to find questions, so better don't use that. The very first question, as Robert, you can see, is from Jim Weston, asking about what about the routine clinical practice where the innovations can come from rather than only from academics. And I see a sort of wisdom in his question because physics is good to base the research, but it can be beyond physics. So over to you, Robert, for this question from
Yes, there is a subtle and very important part of this question is drive to use imaging well. And I think this is where the clinical medical physics has a critical importance of education, as well as making sure that the systems that are in place, the images that are taken are of high quality. The quantitative imaging space part of that I just barely touched is firmly in the domain of medical physics. So I don't think that, I think the high quality of imaging is really important to bring it both from the clinical medical physics perspective, so every day, but also from the research, because the things that I showed, the examples of novel use, that comes from clinical trials. So that's done through the research. And that's why I think we should all together push for the appropriate use, not overuse, appropriate use of resources, as well as then like multiple aspects of novel imaging as novel imaging applications. So it applies equally for research as well as in clinical practice.
Thank you, Robert. Maybe you can stop sharing the presentation so that people can see you better.
Sorry. Yes.
No problem. So next question is from Mark Kessler, complementing and then talking about the educational aspects at the undergraduate level in physics department. So how can things be handled at that level?
Thanks for the question. Yes, it is that I think the question is of the both at the undergraduate level, but I think it's also partially the dilution that I would say that's maybe even more important is that the dilution of the people that we get into medical physics. That I don't think medical physics is seen or is there in many physics department is seen as the career for those who are really strong in physics fundamentals. Not to saying that any one of this is not, but I think we don't see like what we've seen, like a surge of really smart, academically, how to say, oriented physicists that went into, let's say, astrophysics, particle physics, and so on and so forth. So I think part of that, it doesn't mean that they're not good physicists, just mean that like, some of the academic rigor that sometimes is required to move in academic space is maybe not as present. But I would definitely agree that there is some dilution also in that. But I think that's something at best we can go with the trends.
Thank you, Robert. The next question from Ricardo Terini is also on the similar ground of education, developing on curricula, update of curricula.
Yes. And kind of like wearing some of my educational hats, I think medical physics education has to dramatically change. I wouldn't say that. I think for the clinical aspects, I think we've got a really, really well thought systems that will need to continually adapt, because obviously there are new skills that are increasingly needed. And that's something I don't worry about. What I do worry about is like providing opportunity with the training opportunities well beyond the current horizon for somebody who wants to go into the fields that are beyond current medical physics, needs skills and training of that. So I think we need to prepare like parallel tracks, and not that they're not possible, but like formally having those that would go into either academic, more focused academic, those that would go more in the clinical, and those that might go more into industrial or other careers. So I think we need to rethink.
Thank you, Robert. The next question is from Joseph Rugut, and it's a question pertaining to the accreditation system in which we have gone into. If a biomedical engineer wants to be a clinical medical physicist, so how to think in that direction? So there has been a lot of compartmentalization.
So, and this is very hard to answer in general. As some of you might know that the requirements for, let's say in US, for getting into a CAMPEP approved residency require CAMPEP approved training programs. So some type of programs that's different in different countries of the world. I don't think there is, so I don't want to sound like the BME is our enemy or not able. It's just the opposite. I think BME and engineers are our closest friends and allies. And, being editor-in-chief of something that I believe is like the trinity of disciplines, which is medical physics, biomedical engineering, and biophysics, I think these are disciplines that really need to get together. But obviously there is some certain training aspects that are special, but not necessarily required for everyone, especially not necessarily in the clinical space. I think a lot of that with people that are open and get some training, any of these disciplines can cross the boundaries.
Thank you, Robert. The next question is from Elizabeth Yoshimura, asking about the role of medical physics and biophysicists in the models you presented in immunotherapy.
Yes. There is a big, for some small difference between biophysics and medical physics. I think in some sense, obviously, biomedical spans the space of scale. Typically, I would say when you're at the level of the cell and below, then you talk about biophysics. When you go at a level of tissue and above, then becomes medical physics. And biophysics traditionally would be more in concerned with the interactions between the molecules, interaction of the drugs with the molecules, etc. Medical physics is. So it's really spanning the scales. And that's why it's important to combine the knowledge. And biophysics is different than just knowledge of the biology and cell and tumor biology that one would need in order to understand this. So definitely, again, interplay between the societies, but very nicely and well developed. So I think there is a lot of modeling. So biophysics does a lot of modeling of molecules and interactions and response at the cellular level.
Thank you. There is a question of what is nowadays the definition of medical physics.
I think you can go and, of course, like our friend Wikipedia has the answer for that. But to me, medical physics, more importantly than definition, is the aspects of medical physics which are very much intertwined, and that is medical physics as a discipline, scientific discipline. It's something that we talked about, where we are pushing the limits of the aspect of physics. So physics tools apply to medicine, and medical physics as a profession or a job. And I think this is, so there are two very important distinctions that are sometimes misunderstood not for good. And often, there would be people that understand, they would say, oh yeah, medical physics is only what people do in the hospitals, and not consider that it necessarily is a science, or the other way around. So I think it's more important, like to keep this aspect. They're really making the medical physics one and very unique discipline, not common to any other. Something to be very, very much proud. So everybody should just be thankful to the counterpart on any part of the spectrum of medical physics.
Thank you, Robert. There is a question from Alastair Syme on the impact that CAMPEP-driven standardization had on the homogenization of academic skill. I think I will see this question in the opposite side also. The harmonize and homogenization kills creativity. Does it do that really? It tends to drive people in the same direction. It has its own advantages, but from the point of view of innovation, what impact it has?
Correct, and I completely agree. I think CAMPEP and other societies, like we got the same thing, you know, from in Europe, like IFOM, Australia, and elsewhere, have done, I think, tremendous and really impactful job in standardization, which is important. You know, I like to say, when you go to the doctor, you don't want to say, okay, I'll try this or try that. You know, you want a well-trained doctor that knows the state of the art, what's happening today. However, at the same time, and it's not prohibiting in any way, by the way, but it is also needs to better create opportunities for those who want to break the rules, who want to innovate, who want to explore. And, you know, you can only do this when you're comfortable with what you're doing. So physicians are you know, exploring new treatments based on the knowledge of the current state of the art. And this is exactly what we have. You know, like the CAMPEP and others have created the state of the art of today, but we need to open opportunities for those. So I don't think it has stopped in any way innovation. I think just the programs maybe have not opened up the door for the innovation, at least in the US.
Thank you. In view of large number of questions still pending and another only 2 or 3 minutes, so there is a quick, maybe you can give a quick response to how can we collaborate. Perhaps they can be in touch with you by email. Is that fine?
Yeah, if you want to collaborate, send me an email. And I think that's one of the best way. I think there are so many ways. I think as I mentioned before, like Astra Physics is launching some of the collaborative initiatives around the grant challenges. You'll see that's part of like creating working groups around that. But however, I think we need to come together even more than that. And I would love to hear everyone's idea of how we can come together. I do hope that Global Research Scientific Innovation Committee, together with partners anywhere around the world, other societies or individuals, we can pull together something that would be resembling or starting to resemble larger collaborations, as we've seen in, for example, particle physics, astrophysics. I think something that physicists can really master, but we have not.
Thank you. A question from Ivan Rosado Mendes on in the research on biomarkers for immunotherapy response. Experiments were done in cell lines. Can you comment on the effect of the ECM?
In fact, the experiments were done in mice. So they were like cell lines, but there were mice that were transplanted with the tumors, but not in that. We didn't look like too much in the environment. So the main focus of this was basically focusing on the parameters that were there in the model.
Thank you. Maybe we can take one more question. Anonymous attendee, how then do we differentiate ourselves from highly specialized fields that would be better at tackling the grand challenges that you presented, that is biophysics for immunotherapy?
So here I'll politely disagree. I don't think other fields are any better to tackle these grand challenges that we are. Essentially, I think that medical physics is by far the best discipline to tackle. Now, with one caveat, I don't think we can pretend that we know biology. I don't think we can pretend that we know medicine enough, but we are really good translators. And I think that's an important one, that we are translators into these fields, into medicine, biology. However, with a very fundamental knowledge and very important knowledge of physics, the methods, measurements, uncertainties, modeling, mathematics. And I think that's our strength. And I think that unique strength that we are sitting both at the basic science and clinical science is really the trademark and something that makes us so unique that we are actually the one that are most well poised to answer these questions.
Thank you so much, Robert. I think we need to stop because of the time, and I really feel sad that there are so many nice questions which we do not have the time to attend to. But as I said, that we will see if we can have a system established for sending it to speaker, getting and then making it available on the website. So that part we have not tried, but we will try. Thank you so much, Robert, once again.
Yeah, I'm happy to so answer this question. I'm happy to type them up, and then also, yeah, you can post them. But anyone who is interested, let me know. Interested in just about anything that I talked about, wants to participate, want to collaborate, send me an email. I'm looking forward to hearing from you. Thanks again, Madan, for hosting this, and thanks again to IOMP. Very important effort that that World Medical Physics is doing already. So,
thank you, Robert, once again. There have been questions about the recording. Always we make recordings of all the webinars on the IOMP website. Just put in the Google IOMP recording or recorded presentation, and you will reach that. And there have also been number of questions on certificates. So far we had not been giving, but we are now from this webinar, from this year, this is the first webinar. We have geared the system, so we should be able to give certificate of presentation. And then in the coming months, we have also in pipeline the system to give CME credits. So we had established a task group independent for that. The framework has been created. So we are on that path. And for the next webinar, I will share the screen. The next webinar, if you go to the homepage of the IOMP and then click here the webinar, and you reach the webinar page. So this is today's webinar, and the next webinar is by Professor Ehsan Samai on 9th February. He is going to talk to us on image quality monitoring, medical physics 3.0, and patient-centered care. So this is, I welcome you to join next webinar. Please register, and we, as I mentioned, if we go to the next page here, all the recorded presentations of previous webinars are available. So with that, I thank you very much, all of you, for participating in the webinar today. And it has been a lively discussion. And I wish to thank Magdalena Stuva for all the logistic arrangements. Thank you once again. Have a wonderful rest of the day or evening or good night as appropriate. All the best. Bye.
bye, everyone.
Bye.